stool, is it a boy? Is it landing down? The girl is laughing, and cookie jar um, okay, window, curtains, and out the garden, and trees, low grass.
All right, so what you're seeing in that video is a woman trying to describe the cookie theft picture. And the cookie theft is a classic picture out of the Boston Diagnostic Aphasia exam, or the Boston. And it's basically, you can pick up your phone and search it, and you'll see it. It's a very famous image that speech therapists use to elicit connected speech. But what an appropriate description of the cookie theft should be is that there's a boy and a girl, and the boy is standing on the stool reaching for the cookie, but he's about to fall because the stool is tipping over. And the mom is washing dishes, but the sink is overflowing. So your guys with transcortical motor aphasia, they are going to look a lot like your people with Broca's aphasia. They're probably going to have the significant contralateral hemiplegia. One benefit of transcortical motor aphasia, well, two benefits, is that repetition is preserved because the arcuate fasciculus has not been damaged. Also, if the lesion is anterior enough in the inferior frontal lobe, if it gets far enough away from Broca's and the base of the primary motor cortex, then this individual is going to be much less likely to have the accompanying apraxia of speech that you almost always see with people with Broca's aphasia. Now, thinking about Broca's aphasia, let me take a step back to Broca's. Think about it this way. Between the aphasia and the apraxia of speech and the dysarthria, odds are he can't find his word. Even if he can find his words, he's going to have trouble getting together an appropriate motor plan for the articulatory production of that word due to the apraxia of speech. Even if he is able to do that, his articulation is still going to be negatively affected by the presence of the contralateral spasticity that is affecting his articulators, that is unilateral upper motor neuron dysarthria. So someone with Broca's aphasia has a lot of the cards are stacked against them in being able to appropriately communicate. And on top of that, for Broca's aphasia, I can't just give him the word because he can't repeat. So if I say, "What's this?" and if he can't find the word, I can't just say "cup," and he would be like, "cup," because he doesn't have that preserved repetition. Whereas transcortical motor aphasia, if these guys, if they can dodge the apraxia of speech and have a preserved repetition, then they have a lot more going for them. First of all, if they can find their word, they're probably going to be able to get out some intelligible production of that, despite the likely presence of a unilateral upper motor neuron dysarthria. And therapy will go much smoother, because if they can't name the object, if they can't think of the word, you can literally give it to them. You can produce it, and then they can repeat after you, and you can say, "Great, now point to this and say cup 10 times." And they can drill the word, strengthening that connection in their mind between the verbal production, cup, and the stimulus of the actual cup. So your transcortical motor aphasia guys tend to be less severe than Broca's aphasia. They still have significant anomia, meaning that they tend to be very non-fluent, but still have functional auditory comprehension. As we mentioned, they have more intact repetition than Broca's. MLU is quite short, so once again, 0 to 5 words. 5 words being very long MLU, probably more like 2 to 3. Like Broca's aphasia, they have mostly content words, lacking mostly functor words. Like Broca's aphasia, they have mostly content words in their speech and lack almost all functor words. They have a lot of phonemic paraphasias. Like people with Broca's aphasia, they are going to struggle to get better. They're going to be aware of their deficits. They're going to be very frustrated at times, very upset at times. Pretty much everyone with a non-fluent aphasia, they are going to break down and cry in therapy at least once, odds are, because they are going through a lot and they're aware of it. But they're going to fight to get better. These guys also tend to have some preserved automatic language, and they can have some perseverations in there as well. And of course, global aphasia is your most severe aphasia, and it is categorized as non-fluent simply because of the extreme expressive deficits. It is the result of damage to the primary branch of the left middle cerebral artery, which cuts off blood flow to the entire zone of language. These guys are profoundly anomic. They're profoundly non-fluent. If someone with global aphasia, probably 1 to 2 or 3 words may be all that they have left. And that may include perseverations. That may include preserved language. They're going to have really poor receptive language because vernix area is damaged as well. Extremely poor repetition. They're not going to be able to repeat. They're going to have an extremely dense contralateral hemiplegia. And all the problems, all the motor problems and motor speech problems and swallowing problems that come along with that. They're probably going to have severe apraxia of speech because so much of the inferior posterior left frontal lobe is damaged. Reading and writing is going to be significantly impaired. And if you think about the zone of language, I mean, it's like 40% of the left hemisphere. So if you lose 40% of one hemisphere of your brain, you're going to have significant cognitive impairments. You can't lose that much of your brain without being impaired in lots of different areas, as well as having sensory difficulties and sensory impairments because you've knocked out so much of the parietal lobe and the occipital lobe and the temporal lobe. These guys tend to have a lot of perseverations. They can have stereotypic utterances, like the guy we saw earlier that was identified as having Broca's aphasia, but that was tono, 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 that guy. What made him not globally aphasic was that he had a pretty good understanding, it seemed, of what was being asked of him. You know, when the woman coached him to count to 10, he held up his hand and launched into counting to 10. Someone with global aphasia would never be able to do that. They're going to understand, they're going to be able to process language maybe at the single word level, maybe at the 2-word level. So your guys with global aphasia, if they're being brought to you, they're going to be in a wheelchair. If you're going to them, they're going to be in their bed and they're not going to be able to walk. All right, so now let's talk about the fluent aphasias. This includes vernix aphasia, transcortical sensory, conduction, and anomic aphasia. And this is an important image that I like to show in class because, so here's a guy that had an occlusion along one of the primary branches of the left middle cerebral artery. You can see what's left of the artery right here. But this is well after the stroke. So the guy survived a stroke, and all that brain tissue that died, that was the ischemic core, was reabsorbed by the body. So that part of your brain that dies during a stroke, it is dead and gone. It is not coming back. So when you're doing therapy on these individuals, there's nothing you're doing that is bringing brain back. You are coaxing the brain to rewire itself to compensate for lost tissue. And it's able to do that because of neuroplasticity, which is the brain's ability to change itself and rewire itself. And pretty much the older you get, the less plastic your brain becomes. When you work in rehab, you're going to get used to your 60 and 70-year-old stroke patients, and they're going to really struggle and grind their way through rehab. And then that's going to be the norm for you. And then you're going to get like a 25-year-old stroke patient, and it's just like this person is sailing through rehab. They are improving at 3 times the speed as what you're used to. It's because their brain is so much more plastic due to just the younger age of the patient. So getting into vernix aphasia. Vernix aphasia is the result of occlusion of the posterior branches of the left middle cerebral artery. And remember that the angular gyrus is back there. So the more posterior that lesion goes, the closer to the angular gyrus it gets, the more likely reading ability is also going to negatively suffer. Vernix aphasia presents so bizarrely that most people, your layperson, your family members that have someone in their family that has acquired vernix aphasia, they don't know, they're not able to understand it as anything other than dementia or nervous breakdown are the 2 things that people say. Vernix aphasia is characterized by poor auditory comprehension of language, poor repetition, because odds are the arcuate vesiculus has been damaged, but very fluent speech. So they're usually producing a great deal of verbal language, verbal output, but most of the verbal output they produce is empty and meaningless. So their speech is often void of meaning, but as it says here, empty but well articulated and prosodically normal. Your guys with vernix aphasia and transcortical sensory aphasia, these are your guys that there's no struggle at all. They're unaware of their deficits. If they are aware of a problem, they think you're the one with the problem. This inability to acknowledge their own deficits, I'm not talking about the psychological condition of denial, we're talking about the neurological condition of anosognosia. And these guys, they're very laid back because they're unaware of their severe to profound deficits. They don't try to self-correct their speech like people with your Broca's and transcortical motor aphasia might. When people with vernix and transcortical sensory aphasia, when they produce an error, they're unaware of it and they just move on to the next error. And because of their anosognosia, if you try to pin them down and get them to acknowledge their deficits or their mistakes, they can get really defensive. these guys have a lot of neologisms in their speech, and you'll usually pick up on it when you're going through the naming portion of your aphasia evaluation. Some examples of some neologistic paraphasias that I remember, some of my favorites are, so I had a patient with vernix aphasia that called the helicopter a thunderberry, pencil was a Kaufler, and basically everything that I showed them was very much a neologism. Although sometimes you can get some very interesting semantically related paraphasias. One of the most memorable is I showed one of my patients a picture of the broom that's in the Boston naming test, and she called it a dirty brush. Because the lesion is more posterior in the brain, it's much further away from the motor areas. So these guys don't have any significant motor deficits. Unlike your guys with your non-fluent aphasia that have the hemiplegia and all kinds of motor speech deficits, these guys, one of my old professors referred to these guys as being the walkie-talkies. They walk and they talk. All right, they walk into your office probably with a smile on their face, oblivious to their real condition. And the preserved motor abilities can be a problem because they're unaware of all their deficits, but they can still get up and walk out the door and go out on the street and walk away from the hospital potentially. So these guys are very good at producing, they're very good at their verbal output. They produce a lot of it, too much of it usually. But they're very poor communicators because the words that they produce, even though they may produce tons of words, the words are tangential at best and meaningless at worst. And therapy on these guys is difficult because if your patient can't acknowledge or understand that there's a problem, how do you get them to engage in therapy?
Thanks. And say, baseball player, baseball player, baby loose. Okay. Caterpillar, cataloop. Okay. All right. I'd like for you to do some things now with your mouth. First thing I'd like for you to do is stick out your tongue. Stick your tongue. Breathe. Show me how you would kiss. Show me how you love to kiss me. There you go. Good. Show me how you sip on a straw. Can you sip on a straw? See what a sip sticks. See what a sip sticks onto me. Okay. Try this one. See. Wait a minute. Listen. Show me how you smile. Show you plus me. Show plus me. Show plus me. Stop. Can you smile? Can you smile at me? Now don't say at me. Don't say what I say. I want you to do this. Watch. What? Look at me. Smile. There you go. That wasn't a very good one. Huh? Smile. Smile. There you go. Chew. Show me how you chew gum. Chew. So my chews. Okay. Watch this. Good. All right. Cough. Cough. How you cough me? Cough. There you go. I want you to lick your lips. Let me lick my Great.
All right, so when you see this, this is a dramatically different picture than the videos I played you of the non-fluent aphasias. This woman was not able to follow what was being asked of her, and yet she's still producing, she's basically repeating everything that the therapist is asking her to do and not understanding that she's doing it wrong. You see a great deal of impulsivity that is characteristic of vernix aphasia and transcortical sensory. Like, you saw the way that woman was sticking her tongue out. How many, like, 75-year-old ladies do you know that would do that, right? She's very impulsive. She is, as soon as the SLP even starts to ask her to do something, she's almost already speaking over the SLP, completely oblivious to the fact that she may need to actually tune in to what's being said. She's very relaxed. She's doing a lot of smiling. And you can see when she goes to repeat at the beginning, SLP says, repeat after me, baseball, baseball. And she launches into Babyliss, 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 Babyliss. And she's just producing a neologism over and over again as fast as she can, with zero self-reflection on her performance and zero insight into the fact that she is doing it incorrectly.
I'm going to ask you some questions, and I just want you to answer yes or no. Okay? Yes or no. Is your name Smith?
What are they? What they're eating about? I don't know.
Is your name Brown?
Oh, Mr. Triangle, when listening and walking, those things this and here for these.
Just say yes or no. Okay. Is your name Brown?
But it is here, then let me see, I just don't know. No, I'm not going to eat any if I know.
No. Are the lights on in this room?
No. I just don't try what you're doing, and you're just sitting walking around here.
You're doing fine. That's okay. I know it's kind of hard for you, but you're doing fine.
I can eat my own before and everything like that, and cleaning my it's always clean if I'm eating, and I can watch and everything in the morning.
I see.
In hearing this audio clip, you could get a good example of a patient with vernix not understanding what's being said to them, not being aware that they don't understand what's being said to them, and responding with strings of words and neologisms that essentially have no meaning and certainly don't have any meaning in context of what's being asked.